webinar series is put on by the CPHA Health Equity Coalition and supported by Rocky Mountain Public Health Training Center. And so we'll later be joined by Ashley Wheeler-Bell, who's the current senior director. So we'll wait to hear from her towards the end, but I just wanted to share that that's who's putting this on. I'm helping support as professional development chair. And so today we're going to be hearing from Jerreed Ivanich, who's a colleague of mine and a researcher in the Center for American Indian Alaska Native Health at Colorado School of Public Health. We're going to skip any formal intros because he's a very personal and informal guy, and so he'll be sharing a little bit of his background and his perspective today. So Jerreed, you're welcome to take it away whenever.
Thanks so much, Sarah. I really appreciate it. It's good to be here with you all. So I'm new to Colorado. I just moved here in July, so it's exciting to kind of branch out of my little bubble. I haven't got to explore too many programs or see what other folks are doing. So I'm excited and was excited to be invited to do this with you all today. So I appreciate you all joining in. I'll go ahead and start sharing my screen with some slides here, but I do want to keep it fairly informal. If folks do have like a burning question, or if I'm saying something that's just nonsensical and you just want to jump in, I'm not offended in any way. If you just unmute yourself and kind of chime in, I'll go ahead and peep down and we'll talk it through. But if you have other questions, feel free to put them in the chat, or we can wait until the end. So with that, I'll go ahead and start sharing my screen here. And so I'm excited to talk a little bit more about resilience of American Indian Alaska Native communities. Again, like Sarah mentioned, my name is Jerreed Ivanich. I'm an assistant professor at the Centers for American Indian Alaska Native Health and Department of Community and Behavioral Health. I'm a member of the Metlakatla Indian Community in Southeast Alaska. So I don't know how many people are familiar with Alaska geography, but so that little red dot down there at the bottom, that's the island. The last reservation in Alaska is Metlakatla. It's just southwest of Ketchikan. And I'm like I mentioned, I'm new to Colorado. I finished my degree at University of Nebraska, but then went and did a postdoc at Johns Hopkins Center for American Indian Health in their school, their Bloomberg School of Public Health. And so I've got two beautiful kiddos and a wife, and they always make me look better. So I like to share pictures of them because it's better to look at pictures of them than look at pictures of me. So, but I just want to give a bit of an overview of kind of the agenda of what we'll be talking about today. I give a little bit of population overview. I'm guessing there are a handful of you that work directly with Native communities, but there are also probably a handful of you that don't have much day-to-day interaction with American Indian, Alaska Native, or tribal communities. And so just so that we all kind of have a base and a foundation to work from, I'll just be giving a brief kind of an overview of American Indian, Alaska Native public health here in the US. And then we'll kind of move on to some particular health services and statistics that I think are of interest for public health officials to know, especially those of you that don't typically work with Native communities. I think this will be we'll just be scratching the surface, but I hope that this gives you a bit of an overview of what it's like and what some of these communities are working against in some ways. And then we'll jump into a more specific conversation about COVID-19 and American Indian Alaska Native communities and their response to that, and what they're doing and how they've been resilient in the face of all opposition, and how we as public health officials can learn from that. I'll go ahead and end with a shameless plug. I'm not going to tell you too much yet. I'm hoping that that's a bit of a cliffhanger, and then we can all wait to the end to learn more, but nothing super exciting, but just want to talk to you a little bit about a program that I'm involved with, and I hope that you'd all want to know about as well. And so by show of hands, or like reactions, you can do a thumbs up or whatnot if that's easier, but I just kind of want to know a little bit more about how many of you have had like a high school or a college course in American Indian or Alaska Native health. Has that been I can see, okay, now, okay, I've got a couple of thumbs up. Okay, good. So now thinking through, what about on anything? So it wasn't necessarily Native health, but on any subject related to Alaska Native or American Indian communities. Okay, so I'm seeing a couple more thumbs up. That's good. Okay, now hopefully, how many of you can say with at least some confidence that you've had at least 4 hours in total in schooling on American Indian, Alaska Native, like anything? Okay, so I'm seeing more thumbs. That's good. That's good. Good. So I hope that as everybody else was kind of looking at the screen and hopefully seeing the reactions there, that by and large, many of us don't have the opportunity to have formal education around this population, even though they're the original stewards of this land, and a lot of what we have today and a lot of our ability to be here today is kind of in thanks to their stewardship of this land. They're not often highlighted in our formal education, and so that's kind of why I wanted to talk a little bit more about this. I also include this this definition or some of these breakdowns of these terms. I think oftentimes folks want to help. I think folks want to engage in the conversation, but something as silly as not having the right terminology makes people feel a little bit nervous about jumping into the conversation. So I always like to put this out here as a reminder and as a way for us all to kind of have some common language. But American Indian and Alaska Natives are those that belong to indigenous tribal communities in the United States, versus when we talk about Native Americans, these are all Native people in the United States and its trust territories and indigenous peoples from other nations that are US residents. So I think oftentimes folks don't know, did they say American Indian? Did they say natives? Did they say indigenous? And I put this out here as a way for us all to kind of have some shared language, but then also for us to recognize that it's not always the same. I work in many different communities around the country, and you can go to some of those communities and they'll call themselves Indian. You'll go to some communities and they say indigenous. You'll go to some and they'll say native. And I think the important thing for us to do as member, I'm a member of the Metlakatla Indian Community, but I'm not a member of the communities in the Great Lakes area, right? And so if they refer to themselves in a certain way, or I think it's important for us not to just have these definitions and say, oh, that then applies to everybody in a very kind of academic way. But these folks have been conditioned or taught certain ways. And so I think it's just important for us to recognize what's locally relevant, what's important to them, and engage at their level, and not necessarily try to educate people about their own background, which I've seen. So I'm hoping that this slide also just makes everybody feel a little bit more empowered to jump into the conversation and engage, and not let that be a kind of a bar to entry. So, and so now I want to talk a little bit about Indian country today. And so thinking through this, so some of these statistics are a little bit old, but they're still fairly accurate. So thinking through some census data, about 6.6 million people identify in some fashion as American Indian or Alaska Native, which represents roughly 2% of the population here in the US. This number, 574 federally recognized tribes and over 100 state recognized tribes. So, I often ask folks in more interactive settings where we can kind of be face-to-face, like ask people to guess how many federally recognized tribes do you think there are? And you'll be surprised. Sometimes you get answers like 15, and then sometimes you get answers like 1,000. And I can also understand why it's a little bit difficult, because this number is always changing. I believe I have a slide coming up here in a minute with a snapshot and a picture as part of that with the number of federally recognized tribes at that time, which was only about 5 or 6 years ago. And back then there was like 563 federally recognized tribes. So this is always changing. And there's over 100 plus state recognized tribes. So again, this isn't to just enumerate people, but also for us to think about and reflect on the fact that there is great diversity in this terminology that we talk about when we say American Indian or Alaska Native. If you say Alaska Native, that's very different. There are very distinct regions of Alaska with very different languages and cultures and songs and dance and worldviews. And so we just have to be mindful of that when we think through and when we talk at a public health level. When we talk about American Indians and Alaska Natives, oftentimes we present them as kind of one pan-ethnic group that all share similar histories, and in some ways they do, and then in some ways they don't. So we just have to be mindful of that as we move forward. And so, some other important statistics here. Back when this data was collected, roughly 20.7% of American Indian Alaska Natives lacked health insurance versus about 9.4% of the U.S. population. And then 26.6% of American Indian Alaska Natives lived in poverty in 2015 versus roughly 14.7%. So definitely some big, huge issues there. And we'll unpack some of those as we talk today. And just a little bit more information about and to kind of drill down on this issue that there is a lot of diversity in American Indian Alaska Natives and how that breaks down and what does that mean. So roughly, I see estimates from about 0.7 to 0.9% of individuals in the US based on different census data indicate that there are about that many, 2.9 million, that identify as American Indian Alaska Native alone. So they don't identify with any other race. And then there's about 5.2 or roughly 2% of the population that identifies as being American Indian Alaska Native with some other combination of other race or ethnicity. Like myself, my mother is Native, she's Tsimshian from Metlakatla. My father's white. And so there are a lot of folks like that. And then there's also differences in urban versus reservation dwelling individuals that identify as American Indian Alaska Natives. So about 70% of American Indian Alaska Natives are urban, or they don't reside on the reservation. So while a lot of what we talk about when we think about American Indian Alaska Natives really tends to go right towards the reservation in that setting, oftentimes for very good reason, it's also important for us to realize that there are a lot of folks right next to you and in different settings that are Native or identify in some way as being American Indian or Alaska Native, but aren't on a reservation. And oftentimes they kind of get left out of that conversation. So just something for us to think about and be mindful of. I mentioned this in the previous slide about how many different federally recognized tribes there are, but then also the diversity in languages. There's so many languages that are still alive. Unfortunately, some of those are dying, but there are an immense amount of effort being made to retain and protect those languages as well. So to just walk through some other, I think, important public health highlights of the health disparities of working with American Indian Alaska Native populations. You'll see here on this top left corner, the U.S. infant mortality rate by race. So you can see American Indian Alaska Natives, the second group there, only behind African Americans. So high levels of U.S. infant mortality. Right below that, U.S. serious mental illness prevalence. So you can see here, again, when you break it down by race in that figure down at the bottom on the right, 5.8 compared to, when you look at whites or Hispanics. So definitely some serious mental health concerns that many of us American Indian Alaska Native professionals, public health professionals are worried about and working on. And then thinking through this percentage of diagnosed in the US with diabetes and heart disease by race. So again, diabetes there on the left, extremely high rates of diabetes in American Indian Alaska Native communities, and then heart diseases, right? And so I think some of the key takeaway messages here is that there are, really serious issues going on, but those are just indicative indicative of wide scope of disparities. And so I'd like to kind of talk about some of those, right? And so while I could continue to just put slide and slide again after of all the different issues that I think, and the burden that so many American Indian Alaska Native communities are faced with from a public health perspective, I think it's also important for us to think through a little bit why that is. And so I think I'm going to start a little bit more abstract and then move into some more kind of tangible logistic issues of why we might see some of these health disparities. And so, I think oftentimes we start at the very beginning of historical trauma and colonization. So thinking through removal, what does that trauma mean? What does colonization mean in terms of diets, foods, relation to the land, relation to language and others, and then what does that mean for your health? And so I think some key takeaway messages here when we think about historical trauma and when we think about colonization is that we think about the history of federal policies that have been designed oftentimes explicitly to eliminate and assimilate American Indian families and cultures were really hit hard. And then when we also think about this time of colonization and historical trauma, it's a time of treaties, right? So, and we can talk about this at length, but there are so many treaties being made in these early days of contact. So in lieu of land being given to these communities, they were promised and guaranteed health, education, food, and shelter for giving up some of those lands. And to this day, many American Indian and Alaska Natives are fighting for those treaty rights. And so we'll talk a little bit more about that as we jump into kind of some of the health system side of things. But oftentimes we get that question of how come your race is special and you get special medical or health care for your race? And it's not a race question. It's a state-to-state question, state-to-state relations question, and treaties question, right? So this isn't necessarily about race or ethnicity as much as it is about the fact that treaties were made and signed by both parties, and one end was upheld and others have not been. So, and so that also comes into play with this last bullet point here of tribes are sovereign nations. And so it's not necessarily just a race thing, but it's a state-to-state sovereign nation's relationship to another state that we're really talking about and thinking through. And so I think one aspect of that, so oftentimes we know a lot about the Trail of Tears and removal, and we know a lot about the genocide or attempted genocide of many different tribes on the East Coast and moving west. But then one aspect that I think is becoming more known and talked about today and its implications for future generations was this era called boarding school. And so I put here a quote. It says, "Kill the native, save the man." So one of the most famous, kind of entrepreneurs, leaders of this effort was Captain Richard Henry Pratt, who started some schools in Pennsylvania and some other places and kind of started the model of boarding schools and traveled the country establishing other boarding schools. This was his ethos and his motto moving forward. At many of his speeches, opening schools, this was kind of the tagline of the speech was, we want to take the native, and as you can see in these pictures on the left, especially this bottom two on the left, we're going to take these native savages and turn them into men, right? So we're going to kill the native and save the man. And he promoted things like, removal of language, culture, art, by even horrifics, force, if you will. And so what does that mean when you are sent to one of these schools because it's been promised to you, and as a parent, you want your kids to have the best. So when you're told, oh, if you just send your kid away, they'll have good education and they'll have a fighting chance in this country, so you do. But then you send those kids away, or they're taken from you, and they're stripped of everything that they know, and they're stripped of everybody that they do know, and they're forced to live a certain way that is completely unique to them. And yet you also have to remember the context in which they're living. So they finish school, yet they have no place to go in kind of a very white dominated space. So they go back to the reservation, yet many of them have forgotten language. They've felt embarrassed to wear certain clothing. They feel it's a negative thing to talk in certain ways, act in certain ways, or engage in the culture. And so you have this big disconnect where folks of a whole entire generation feel completely ashamed of their culture and they don't fit in. They can't leave off the reservation land in many cases because they don't fit in and they're not treated fairly, but they go back to the reservation, and again, they still don't fit in because they feel ashamed of who they are. And then what impacts does that have on parenting, on health, on stress, for multi-generations, right? So I think that's something for us to really think about the impacts of that. And so moving to a little bit less abstract, again, thinking through some of these social determinants of health, thinking through education as one of these big aspects of this. So what percentage of individuals, American Indian Alaska Natives, don't have their high school diplomas? Roughly 18% compared to the average US total population of 14%. Have a bachelor's degree, again, far fewer than the average US totals. And then what percentage are living in poverty? And so depending on the source that you're getting this information, that number can fluctuate and changes from tribe to tribe, reservation to reservation, and community to community. But regardless, those rates of poverty are extremely high. And then thinking through median household income reported, much smaller than US total averages of median household income. So some real tangible differences in what we can expect in terms of health when we know that one of the strongest predictors of health is education and poverty, right? And so American Indians, Alaska Natives are among the poorest and least educated. They're often in communities which lack access to healthy foods and safe physical exercises. And the result of genocide, colonization, racism, and dependency economics throughout history, right? And so these things continue to perpetuate and they continue to have health implications. And then I think diving down to a very kind of concrete dollar per dollar aspect of why we see some health disparities among American Indian Alaska Natives. So when you look at how funding dollars have been allocated through the years, so you can see even right here, IHS in 2012, federal dollars per capita spent, $2,849. And you compare that to federal prisoners data 5 years prior to that. As someone who received his bachelor's and master's in criminology and criminal justice, I'm not necessarily advocating or suggesting that it's unfair that federal prisoners receive $4,400 per capita, but I think it's also a huge error on our country's part when they've made treaties to protect and maintain the health of American Indian Alaska Natives. They're just not funding it at the same level that they should be and that they've promised. So oftentimes IHS, or the Indian Health Service, is at the mercy of congressional appropriations. So the ability to advocate and truly put their word out there is really at the mercy of congressional appropriation. And then that's also thinking through kind of those that live and reside on reservations, but then the amount that is appropriated that goes to urban natives, although we see a huge number of folks that identify as American Indian Alaska Native here in the country actually reside off reservation land, but their funding is quite small. So these are just, again, we're just scratching the surface. This isn't meant to be completely holistic or a really deep dive, but just to give us an understanding of kind of like both abstract level, but then moving down into very concrete, tangible reasons why we would expect them to have poor public health outcomes. I think there's money and there's history there that really kind of lead to some of these health disparities. And so,
hey, Jared.
Yeah.
We just had a quick question in the chat for on that slide what NHE stands for, if you know.
Yeah. So this one right here, NHE, is that what you said?
Yeah.
You know, actually, I'm not 100% sure. I can look that up, but I actually don't know off the top of my head. I'm sorry about that, guys.
No worries. I'll look it up and send it in the chat.
Great. Were there? This is kind of a good stopping point. This is a lot of kind of that front end, kind of like building a foundation for us all to then jump into the kind of the meat of this conversation. Was there any other, lingering questions or concerns that anybody had before I jump into kind of this more nuanced discussion of COVID-19 and American Indian Alaska Natives? It's okay if we save discussion till the end. I just wanted to give everybody an opportunity. Okay, I'm going to go ahead and keep moving forward, but again, feel free to stop me or speak up if I need to slow down or whatnot. I'm just hoping to leave some time at the end for us to chat. So, so thinking through COVID and American Indian Alaska Native statistics. So there's a big asterisk here at the end. That's mostly because these things just change on a daily basis. We all know that. We're all in some way or shape have some professional relationship to public health, and we know what's going on in the pandemic right now. Things just change daily, weekly, monthly. So while some of these statistics are put out there to illustrate the point, if we looked up the most current rates, they may be worse, they may be better. And I apologize that we just can't have the most up to date, but these things are changing on us minute by minute. So, but generally, it's safe to say that American Indian Alaska Natives see rates of COVID about 3.5 times higher than that of non-Hispanic whites. So definitely really high rates. In cases significantly higher among individuals younger than 18. So while I think that conversation that gets put out there all the time, and folks are often kind of, especially in my age group or, 50 or younger, folks tend to have this, well, I'm probably okay. I'm not in that high risk category, or this isn't happening as often to folks in my age range. Within American Indian Alaska Native communities, we're seeing really high rates, significantly higher rates among individuals that are younger than 18, which is something to be concerned about and to think about. But one thing that I also want to highlight is that there tends to be less cases among those that are 65 or older. And we can kind of talk about through some of those things as we move forward, but I just wanted to kind of set the stage for us. There's a lot of work coming out on this topic in kind of peer-reviewed journals. I'm guest editing a special issue on this exact topic right now. And so as much as I'd like to talk about all those things right now, those haven't been thoroughly vetted and accepted and published quite yet, but there is a plethora of work going on right now to really put out there the current public health state for American Indian Alaska Natives as it relates to COVID. So hopefully some of that informal background I can bring into the discussion, but I didn't want to put it right here quite yet. And so thinking through, why would we expect to see some of these high rates beyond what I've already talked about? So I think that there's some environmental, social, and cultural implications for why COVID-19 is particularly dangerous for American Indian and Alaska Native communities. So as we've already seen, these communities are often burdened with high rates of underlying health conditions. So that's something that we need to be really mindful of. So when we see that it has a horrible impact in Native communities, it goes hand in hand with the fact that many of these communities have underlying health conditions that we need to be worried about and thinking through. And then also contact tracing is extremely difficult in many of these rural communities, and working with American Indian Alaska Native communities, how do you do contact tracing when everybody doesn't have a reliable phone, and when there isn't landlines, and when there isn't the internet infrastructure to really get some of that work done. So contact tracing can be very difficult to do. Transportation issues, so folks can't get to hospitals until it's extremely dire. So when you live in rural communities and the hospital is an hour and a half, 2 hours away on very rural terrain in the middle of the winter, if you just kind of have a couple of coughs here and there, it's usually pretty easy to kind of just say, oh, I'll be fine, right? And until it becomes really bad, and then you go to the hospital and you've already infected several other people and your condition has worsened quite a bit. So that's a huge aspect of it. Poverty, something that we've already talked a little bit about, but is a huge driver, as many of us already know. Multi-generational households. So when you have folks that are grandparents and great-grandparents, parents, and the children all living in one home, we see high rates of spread. And when all of those folks, because of what we know about homophily and how people tend to sort and how relationships tend to work, we know that those people aren't just catching it in that household and that they're not just transmitting COVID within the household, but that they then tend to branch out into different networks that are unique from the other members of their household. So you have more avenues of unique transmission strains than if everybody was in the same age bracket, then the transmission strains would likely be a little bit more narrow than in multi-generational households. So it's not just about within household transmission, but beyond that, how does that look? So that's something for us to think about as well. And then healthcare systems. Again, I've touched on this before, but IHS is extremely overburdened and underfunded. And then also when you live in communities in Alaska or in rural America, and it's extremely difficult to get to some of these clinics or healthcare systems. And then once you get there, the systems are often don't have the equipment necessary. I've talked to several tribal members. I was part of the team. If you go to the Johns Hopkins website for tracking COVID-19, Hopkins allowed us to petition them and put on that tracking website, there's a specific tab for tracking COVID cases within tribal communities, which I think is huge. And I think that's great for data visibility. But when you think through how that gets dispersed and those numbers are extremely, the numbers are really high. So when you look at a community, you'll see that their IHS facility is overburdened, and even the surrounding communities next to them are. So when you live in one reservation and your next biggest city is saying, no more, we're not accepting any more IHS patients, they have to be sent to, other cities literally on plane and helicopter. And so this is really having huge implications for health, mentally and physically, for Alaska Natives and American Indians. And then again, I can't bring up enough historical trauma and the role it plays today for folks. But this has all been fairly kind of negative, and I don't mean for it to be, but I think it allows us to understand and be motivated and address the issue and thinking through that. And so I think oftentimes folks are extremely quick to be like, oh, well, they have problems. Here's how we can fix it. And which I think is good in ways, but then also times, I think it's important for us, when I think about American Indian Alaska Native communities, I don't see weak people. I don't see broken people. I don't see broken communities. I don't see a problem. I see resilient people fighting an uphill battle, but they're resilient. They are here. They are strong people. And so I kind of wanted to highlight some of that resilience today and talk through why it's important for us, especially as public health officials, not to get stuck on kind of the excuse my lack of a better term, but the poverty porn of it all. How can we really actually understand what's there, the resilience that is already existing in these communities, and learn from them, strengthen them, and lift where they stand to really make a difference, instead of an outsider coming in and saving the day every time. And so one of those aspects that I wanted to talk about, and I think is extremely important, is tribal sovereignty. So we've touched on this a little bit, but I think there's opportunities for us to think about and look at data that are coming from some of these communities that exercise their tribal sovereignty, especially in the Great Plains areas, where they shut down their borders and they sent out all resources to those border checkpoints and really made sure to, if you weren't there for essential travel or essential goods for the reservation, you were turned away. And while that made several governors very upset and they told them they couldn't do that, they had that right in their tribal sovereignty to protect their people. And so when you look at those communities that really acted quickly and were very proactive, and I think at the beginning and the onset of this, folks were saying they were overreacting. Yet when you look at their numbers, even today, while cases are extremely high everywhere, you'll see that their rates are lagging behind everybody else, because they've really taken to that ability to exercise their sovereign nation power and authority to protect their people. And so their rates are extremely low when you compare that to communities that didn't exercise that, right? And so tribal sovereignty is extremely important here, and something that we should learn from a public health standpoint, empower that more moving forward. Another thing that I really wanted to talk about were cultural values. And so I mentioned earlier that rates among individuals 65 and older were lower than what we're seeing nationally. And I think this is an empirical question, and this is me speculating. I don't want anybody to like take this to the bank, but I'm willing to put my hypothesis out there that a lot of Native communities value their elders, and because they value their elders, they know who they are, they know who are most at risk, and they've made efforts to, they were some of the first communities to really offer delivery services, even in rural communities, delivery services to elders and those that are a little bit older, or they were the first to receive resources like portable hand washing stations, food, and the like. They were the target of a lot of public health education and outreach efforts in many communities as kind of the most vulnerable. And so I think that there's been a huge, because of this cultural value of elders as kind of the knowledge keepers in communities, folks have really rallied around them. And I think because of that, they've really tried to protect. And I think we're seeing that in the data. But then also, I think when we think about cultural values, I think there's things like, what can they do even in periods of despair right now to really come together and strengthen their youth and strengthen their population, both physically and then also mental health wise. And I think that those are some really important questions moving forward that we as public health officials can learn from. And those are empirical questions that we can learn from. So something I wanted to highlight as well. Food sovereignty, I think that this pandemic has really highlighted the need to return to and place some value back on food sovereignty. So, I think many folks that do work in rural settings or in settings where there's high levels of poverty understand the importance of food deserts and access to healthy foods and foods that are sustainable. But I think this pandemic has really highlighted that in the wake of lockdowns and inability to travel and get out as often as safely. I think that this has really called attention to many folks on tribal lands, the importance of returning back to some of that food sovereignty and really having a say and a return to some of those healthy foods that can be grown and cultivated and eaten by their community members that have historically always been healthy for them. And so I think it's another aspect that we're learning from this COVID-19 as another source of resilience for American Indian Alaska Native communities, again, that are not specific to those communities, but can really be dissected and understood from a public health perspective. How can we learn from that model and take it back to other communities to be beneficial elsewhere? And then thinking through, again, community, while I think there's definitely some overlap between all of these different sources of resilience, I wanted to specifically call out community here, because I think while I mentioned earlier contact tracing is extremely difficult in many communities, there are communities like the White Mountain Apache community support financially, but then also infrastructure in terms of expertise to teach, train, and support community members to do contact tracing. And because of that, we see while some of those Apache communities have extremely high rates of COVID, oftentimes upwards of 10 times the rates of the rest of the state, which Arizona is already extremely high, they see a fraction of the rates of death. And a lot of people attribute that to the fact that contact tracing in some of these bigger communities were hit on really quickly, really fast. And because of their local knowledge and ability to come together and know who's who and how to connect folks and the unique circumstances of people, they were able to get the word out there and contact trace quickly. So you had a lot of people testing very early until before they were symptomatic, before presented issues, and were able to get the healthcare that they needed proactively versus being, you know, going and getting healthcare before, after it was too late. And so I think that there's different aspects of community that I think are a source of resilience for many of these communities that can really be learned and seen as a model moving forward for those that do work in rural health or in other communities that face similar poverty or education or infrastructure issues. There's still ways that folks can be resilient in the face of that. And so, again, I just wanted to highlight some of those topics that I've been talking about in terms of contact tracing. I just mentioned that community engagement, how engaging the community members can really provide unique insights and problem solving, high risk populations and governance. So again, we've talked about how many people in these communities know who are high risk and how they've really protected them and made programs at a governance level and at an individual level to really protect them. What we haven't had a lot of time to talk about today, and I'm happy to talk a little bit more about it, is the importance of data and misclassification and data sovereignty and what we can do there. And then we need to continue to improve healthcare systems in these communities and get them the funding that they deserve. Food sovereignty, protecting elders, all these things we've talked about. And so in the wake of our time constraints, I'm going to kind of keep moving forward so we can have a bit of a discussion. I'm going to keep moving forward, but I'll have these slides available to anybody that would like to have them. And I just want to highlight something here. So we're going to skip some of these quick questions that I have here. You know, I put these in because the next thing I want to do is, as I'm quickly learning, as someone new to as an assistant professor, I'm learning more and more that a lot of your ability to continue to do work is about, you know, self-promotion, sadly enough. And so I'm the director of the American Indian Alaska Native Health Certificate at University of Colorado Anschutz Medical Campus. And so I just want to make folks aware on this webinar about that program, because I think even if you aren't interested, I think it's opportunity for us to be educated about what's out there. So if you interact with folks, you can tell them about this program, because many people don't know it's a program. And so in the development of this, there's an old American Indian proverb that says, tell me and I'll forget, show me and I may not remember, involve me and I'll understand. So we're hoping to build a program that's very involved and really incorporates folks at the community, because it's completely online. And so I put this here because this shows kind of the US population, and it shows where some of these programs are. So the only other two programs that we are aware of are in North Dakota, and then also at Johns Hopkins in Baltimore. Both of those are in-person programs for similar public health training in American Indian Alaska Native health. But our program is going to be completely online. We're the most westward program where most American Indian Alaska Natives live. And so we're hoping that being online and being a little bit closer will allow folks to engage, and even so much so that they don't have to leave their reservation or their tribal lands. The faculty that teach the course are all from the Centers for American Indian Alaska Native Health and the Department of Community and Behavioral Health. And like I mentioned, these were the other programs here. And then we'll be starting this program moving forward in the spring. And we're doing it all online. So we hope that the research extends, provide flexibility for those that are doing work in their own community so they don't have to leave. And then we hope that this generates creativity through multimedia learning and a host of different community members coming together and really sharing life lessons between them. The certificate is a 15 credit hour certificate program. There are 3 American Indian Alaska Native focused courses. So there's Foundations of American Indian Health, Ethical Considerations in American Indian Alaska Native Health, and then there's 3 1-credit standalone units, Ethics and American Indian Alaska Native Health Engagement, Community Engagement, and American Indian Alaska Native Health, and then Tribal Research and Review Fundamentals, and then also Social Determinants of Health. So these are all some of the core classes that are being taught as part of this 15 credit hour certificate program. And then there's some elective courses as well. And here's some just topics that generally we'll be going over, but it goes so much deeper than this. And for the sake of time, I'm going to keep rushing through here so that way we can have a good discussion. But we hope that anybody and everyone will join. But, you know, more joking aside, I think we hope that practitioners and organizations who serve American Indian Alaska Native people will engage, researchers that are doing work with or in connection to tribal communities, and then also a lot of educators that are teaching health equity courses. And so I hope that wasn't too fast, and I hope we can have a meaningful discussion. I'll have my presentation out there for you all to review if you want, but I'm going to hopefully jump back to more of a discussion time if you guys have questions that I can answer.
I have a question.
Yeah.
My name is Stephanie Salazar Rodriguez, and I'm from Mixed Blood Native American and Latino. And I recently saw an article on the Denver Riot, I think just last week, talking about the statistics here in Denver. And it gave the Native American population as 0.4, but 7.2% with COVID, which is like 7 times higher. And so I saw your statistics that you had, but I wondered if you had seen the article and wondered if you knew where that data had come from.
You know, I actually haven't read the article, but you're the second person that's actually brought up the article. So it's something that I definitely need to jump into and see where they got that data, because I know a host of folks that I'm willing to bet would, I think that there's a lot of qualifiers on how that data was collected, I'm guessing, and who counts and what gets counted. And so I am eager to see and learn a little bit more about that. Can you remind me the where that article originated so that way I can trace that down?
It was in the Denver Riot.
Okay.
Yeah. And then I also just wanted to say one other thing. I actually have 2 jobs, and one of my jobs is working for Connect for Health Colorado. And I am working with both the Latino and the Native American Indigenous community about healthcare enrollment. And I know that Indian Health Services is extremely underfunded. And I was wondering if you knew if there was any particular strategies that we might employ to be able to have the information out about how anyone who's tribally enrolled, how they qualify for benefits that would augment the benefits that they have through IHS. We seem to have had not a lot of people really thoroughly understanding and thinking that if they did that, they would lose IHS, but this is in addition. And so that would really help. What you talked earlier about the issue with health insurance, I'm sorry.
Yeah, no, I think that's really important. And I don't have access to some of those resources, but I know some folks that are actively engaged in those education and those campaigns, and then also working in those clinics. I know some folks in Alaska that work in those, and like you mentioned, those two aren't they don't negate each other and don't make you they don't disqualify you from other sources. Oftentimes, actually, what IHS is doing is they spend a huge amount of their time really trying to figure out how much they can bill out for other resources that folks are eligible for before using those IHS limited dollars. So if that's something you're interested in and some folks I can connect you to, feel free to send me an email. I'm happy to make those connections to folks that are like in the trenches doing that work, because I think it's extremely important.
Yeah, we're doing that here mostly for the urban Indians here in Denver, and we're going to have a big enrollment event on the 9th of January. So I really would like to be able to get that information out to the community as well. So yeah, I will definitely send you an email. Thank you so much.
Yeah, of course. I love it. Thank you so much. Appreciate the work you're doing. Is there any other questions, or did I miss anything in the chat box, Sarah, that I can elaborate more on, or folks have concerns about?
No, not currently. I made sure to put your email too in the chat so folks could reach out back to you. But if anyone does have questions, you can put them in the chat or unmute. Looks like there's one question about if there's any specific COVID themes you're noticing in the Denver area that folks should be paying attention to.
Yeah, I guess I would ask for just a little bit more clarification in terms of what do you mean by themes? Like, do you mean like symptoms, or you mean more like social determinants, or what does that actually mean to you? Just so that way I don't give a misleading answer.
Thank you. I can just talk because chatting is obviously not the best way. Thank you for the presentation. I guess kind of to what Stephanie had spoke about as far as the numbers that we're seeing in the spikes in the Indigenous communities. Is there anything specific to what you already presented that may be swaying more so in the Denver area or not? Like, I know that was kind of more so on a general scale. I know you're newer to Denver, but is there anything that you're seeing as far as how folks should be paying attention or like community engagement for intervention, like anything of that nature?
Yeah, I feel like I feel like I'm copping out here, and I apologize. But you know, being new and having limited access to be able to visit with folks in traditional gathering places, and you know, American Indian, Alaska Native people are folks that gather and are relational folks, and so there hasn't been as many opportunities to congregate and to get to know folks here and the stakeholders in the community here. So I haven't really been able to engage in full capacity, but I know several of my colleagues at the Centers for American Indian Alaska Native Health are fully engaged with the local community, and we have a community outreach specialist at the centers. And I know that she's really kind of trying to keep an eye on the rates and what she's hearing from the community. But I'm not 100% sure what those exact themes or if there's unique factors going on there that put them at unique risk or protective levels compared to the rest of the Denver metro area. Sorry.
No, it's okay. Thank you.
Yeah. I thought I saw someone else unmute for a second. Did I cut someone else off? So I'm just like, these things pop up and they're all over the place.
I have a question for you, Jerreed.
Yeah.
So just, you know, I made a comment about how community can be actually, you know, greater resource when it comes to this type of things. And I was born in a very big extended family system or community system. And so when you think about community spread of COVID, you're thinking that that could be a disadvantage when you're in, you know, a closed knit area. And so I just see it as a strength, but it's interesting that you're saying with, you know, information coming from the elders and leaders that is helping to bring COVID cases down. Can you tell us how, you know, how this community stays so close knit together and how we can do it better in our communities as well?
Yeah, I really appreciate that. So a lot of my work really actually focuses on social network analysis. So this is kind of like the nerdy stuff that I like to geek out on a little bit. So I think it's definitely still an empirical question, and I think that there are more contact tracing efforts and data out there that we'll be able to analyze in the months and years to come to really answer that question. But I think my initial take and from what I know working with Native communities, I think what you mentioned is true. I think being in a tight-knit community or in tight-knit family units, even if they're multi-generational or even if they expand to aunties and uncles and cousins, I think can be a huge benefit. But it also may be possible that those unique networks cause more transmission than otherwise. So we can think about this through one very popular social network theory is kind of the strength of weak ties, or in this case, possibly the kind of the danger in weak ties. So if everybody in this house who are strongly connected all have weak ties to other people, they don't have all the same friends, that transmission may be getting out there in more unique strains. Again, this is just me hypothesizing. We don't really know, and that's something for us to consider. But we also know from some of the data I was presenting that the rates among the elders 65 and older are much lower. So it may be, while cases are spreading among maybe the younger unique ties of networks, it may be that there's concerted cultural awareness of those most high at risk. And so there's extra efforts being made to protect them. Again, these are all just me sitting here armchair theorizing. And I would love to get data on these things and to analyze that. But I think you're right. There's strengths, but then also we need to think about how sometimes those things that are perceived as strengths may actually be points of intervention and points for us to really work on and help and improve. So I know we don't have a ton of time left. I saw Ashley, you went on mute. Did you want to bring up a comment real quick? Sorry. I can't hear you. I don't know if you're still muted or if it's the microphone.
Thank you. I was double muted. Hi, everybody. Ashley Wheeler-Bell here. I'm the Senior Director of the Health Equity Coalition. I want to thank you, Jerreed, for this talk. I found it, I mean, as a person invested in health equity, I've just loved hearing this topic, but also in my day job working to advance in COVID-19 protections for our community and for our state. And so have a million questions, but the main thing that was coming off of my mind was just the tie that you were just on about community and connections within community, but then this cultural component of protection and protection of elders and our loved ones that's really strong in helping protect people. But then I can't help but like have it tied strongly to a mistrust for like guidance and public health practices. Even though you want to protect your community, you don't quite like have the reassurance to trust the advice that you've been given or are being given. And so all of that kind of plays in my mind as like, I think we could really stand to learn a lot from Native and Indigenous communities on how to better respond to this virus than any other virus. And we have to work through this mistrust. And I would love to hear like more about how we can do that.
Yeah, so one of my closest friends and longtime colleague, Alicia Mousseau, she was just elected the vice president of the Oglala Sioux tribe, Pine Ridge Reservation, and I just had a meeting with her a couple days ago, and she was talking through some of their efforts because she's just been put in charge of the COVID emergency response team and also their vaccine distribution plan, right? And so she asked several of us in public health, her friends and colleagues, and she's just saying there's an immense distrust, right? Like she's going to have a hard time getting folks to engage. And I think you're dead on, Ashley. I think this is going to be a hard thing for Native communities, not just in terms of the public health information they've already received on how to protect themselves and the mistrust that's there and the lack of resources to make that happen, even if they do trust it. But then now that we're moving into this new phase, a promising phase, today is the first day a U.S. individual in a non-clinical setting received a vaccine. That's amazing. That's huge. But we now need to start thinking, the Pfizer vaccine, they aimed to get about 200 participants in their study from the Navajo Nation, and we're only able to get about 130 because they just could not convince people to be part of this research, right? Because there's immense distrust. So I think that there are some amazing folks that are doing public health education research, working on health equity efforts, and understanding and coming at it from a listening perspective, I think is going to go miles. And I think also just being in communities, which is extremely hard for us to do right now. But I think we're entering that phase where we need to just be present, even if that means on Zoom. So I think that there are a lot of efforts that need to take place to improve trust and for both being protective, but then also moving forward in this new stage of a vaccine rollout. And so I know that we're kind of coming up on time. I don't want to shut anybody out. If you have questions, I can linger around for a couple more minutes, but also feel free if you've got to go, take off and send me an email if you'd like to engage. I'm happy to, and this has been a pleasure. Thank you so much.
Right. And while Ashley is still on the phone too, I want to give her a chance to say anything she likes about the Health Equity Coalition. And then, yeah, Jerreed, if you have time and want to stick around for questions, that's fine. Or if folks want to reach you by email, Jerreed was very responsive.
Thank you, Sarah. We'll go up against the clock since we're at 1:01, but this webinar and many other offerings are put on by the Health Equity Coalition from Sarah Boland and Marissa Westbrook, who are the leads of our professional development work group. Many of you have come to the coalition meetings before, many of you have not. I just want to use this moment to warmly welcome you if you are able to join us. Oh, look, there we are. If you are able to join us, we meet bi-monthly virtually at this point, and you can email, thank you, Sarah, or whomever is driving this PowerPoint. You can email our membership coordinator at the email below to get invited to all of our upcoming meetings and to be added to our distribution list so that you can learn what the Health Equity Coalition is up to and then also be engaged at a level of your choosing. So thank you very much for your time today, and I look forward to talking with all of you at a future date.
Thanks. Sorry to take your time, Ashley.
No, thank you, Ashley.
No,
and sorry,
I
was just figuring out my screen sharing, so sorry I was cropped for a second. But here are all their lovely faces.
That's quite all right. And I wanted to have this conversation or have time for conversation. So I compromised the moments to plug the coalition in effort to have more conversation. So thank you for being willing to do that.
Sure thing.
Anyone else have anything last that they want to say before we wrap up? Otherwise, yeah, please continue these conversations with Jerreed. And I'm sure he's happy to connect you too with other folks who work with the Center for American Indian Alaska Native Health or the folks he's worked with at Hopkins or in the community as well.
Perfect. Well, thank you so much, everybody. Have a wonderful day. Again, I'm super open. Send me an email. I'd love to talk about this topic and what we can do and partner together.
Beautiful. Thank you.
Thank you, Sarah. I appreciate all the help. All right, bye. Oh, you're muted. Sorry.
Oh, thank you, Mia and Chris, for your help too, and Stephanie for your questions.
It was great. Hope everyone has a good day.
Bye.
Bye-bye.